We have an opportunity now to discuss more informally some of the things that we heard this morning. This is a very rapidly moving field with incredibly expanding possibilities in terms of both the research and the real applications to clinical practice, as we've seen in the last few days with the approval of the first of these new hormonal agents. So I'd like to begin by introducing the members of the panel, and then we'll get on with the discussion. And first, tell us who you are and where you're from, panel members.
I'm Efstathiou. I'm a medical oncologist from the University of Texas MD Anderson Cancer Center.
So I'm Jason Efstathiou, a radiation oncologist from Massachusetts General Hospital here in Boston.
I'm Matthew Smith, a medical oncologist from Massachusetts General Hospital Cancer Center in Boston.
I'm the moderator. I'm Bruce Chabner. I'm from the Massachusetts General Cancer Center in Boston as well.
I'm Oliver Sartor. I'm medical oncology, Tulane University School of Medicine.
I'm Adam Feldman. I'm one of the urologists here at Massachusetts General Hospital.
Okay, I'd like to begin with you, Elaine. We heard about several different new approaches to hormonal therapy, and it's in the setting of refractoriness to conventional hormonal therapy, Lupron and castration. And what interests me is the possibility that these new therapies could be synergistic. Where do we stand in terms of trying to use abiraterone with medivation or with these much more potent androgen antagonists?
So this is an excellent question, Bruce. I think that we're all really intrigued by the idea of combining these reagents together and moving forward to what we would call maximal androgen blockade, and that would require both potent androgen biosynthesis inhibitor, probably in the background of castration, as you mentioned, in combination with novel androgens. But before all this enthusiasm takes over, we should also be very careful in conducting the right trials that would be very informative with regard to the individualized approach and actually pick the patients who would benefit, taking into account not only the cost that is extremely important, but also the long-term adverse event that we should expect to see. I mean, we've seen them with androgen deprivation alone. Imagine going all the way to maximal.
Yeah, so Matthew, you've studied this extensively in terms of the existing hormonal therapies. Do you anticipate that the combination of these therapies would have an even more potent side effect profile?
Sure. So I think it's now well established that androgen deprivation therapy has side effects: loss of muscle mass, increased fat mass, insulin resistance, alteration in lipids, osteoporosis. And some of those metabolic effects may translate into meaningful clinical risks, including potentially greater risk for diabetes and heart disease. So we know that occurs when you go from normal testosterone levels to castrate levels, which is about a 2 order of magnitude reduction. Now we're talking about going with abiraterone, another order of magnitude or 2 below that. And that's a question that has not been addressed. In part, in the past, it could not be addressed because there were no agents that resulted in these really low levels of circulating testosterone. And so I think it is an open question. I agree with the characterization of the tolerability of abiraterone and other drugs in similar class in development as being well tolerated, but they do have some side effects, and some of the longer-term side effects need to be better characterized, particularly as we consider moving these drugs earlier into the course of management.
And in combination, do you think the combinations are likely to be more potent in terms of side effects as well?
So by combination, you mean abiraterone acetate, for example, with
castration?
Well, in all cases, abiraterone is going to be given in addition to standard castration.
Yeah.
I think to back up for a moment, the question about whether the comparative value of abiraterone and MDV 3100 we'll have an opportunity by comparing the results of mature phase 3 trials to get a sense for that. They won't be head-to-head initially. And one, I think, the big questions in the field is whether there's place for both of those drugs. And based on very suggestive data to date about different mechanisms of resistance, I think there's very likely to be a place for both drugs. And then the next question then, if you accept that, is there a role for combination therapy? And I believe there is, and I agree with Elaine's sort of cautions about how best to proceed in that arena.
I guess the next question is, how do we use them with radiation therapy too? And that's that, I guess, would also involve the vaccine. If the vaccine turns out to be as useful in early disease as it seems to be in late disease, that you could imagine that you would want to use it up front in a high-risk patient. Jason, has that thought occurred to you?
Absolutely. I mean, I think these exciting new approved agents are being moved, as Matthew and Elaine have alluded to, in earlier settings. The group of patients we know we don't do that well with that have a curative potential is high-risk localized disease. Yeah. And so combining these agents where in high-risk localized disease, androgen deprivation along with local therapy like external beam radiation is standard of care. So combining these new agents in that setting may increase, the potential for therapeutic gain. Long-term control, and possibly higher cure rates. So this is a question very much being addressed by some of our national cooperative groups and in other settings. Mm-hmm. Your point about immunotherapy and vaccine therapy along with radiation is an interesting one because we know that radiation can rev up the immune system. And so how do these sorts of therapies work in concert with radiation is an unanswered question and an important one.
Yeah. Oliver, where does this leave chemotherapy in the future for prostate cancer? Do you think there's going to be a place earlier in the disease for chemotherapy?
Well, let me take that kind of as two questions. And it was interesting, I was talking to Matthew a little bit earlier, and it's back to the future with chemotherapy. I think these newer hormonal agents are going to be moving toward the front. They're going to go pre-chemotherapy really quite soon. The abiraterone data to date support the post-chemotherapy setting, but I think soon that's going to change. So chemotherapy is going to be sort of working in the background, but we actually have a large trial, RTOG-0521, which is fully accrued over 600 patients to test the hypothesis that early chemotherapy in the high-risk setting in combination with conventional radiation and hormonal therapy, and asking the question, does it add? And we don't know the results yet. If it does add, then we'll have the paradigm of moving chemotherapy up as well. And quite frankly, that's more of a breast cancer paradigm, which people have been asking all along, why aren't we more like breast cancer in the first place?
Yeah, that's right. And if you use the breast cancer paradigm further, you'd think about it being neoadjuvant therapy for high-risk patients who then could be surgical candidates as well. And I don't know if that's happening at this point or not, but are those kinds of trials being considered?
They are. They're actually being conducted. And in fact, there's a trial looking at neoadjuvant for radiation as well. So people are looking in the neoadjuvant chemotherapy setting as well as in the adjuvant, and it's too early to make any comment at this time.
Right. How do you see this impacting your practice, Adam, in terms of early surgical intervention for this disease?
Well, unfortunately in surgery, where we have seen the benefit of the addition of hormonal therapy with radiation, we haven't seen the same benefit with surgery. There are, I think in terms of looking at some of these newer agents, looking in the neoadjuvant setting would be helpful. There are a number of trials. There's a CALGB trial looking at docetaxel with androgen deprivation therapy in terms of in looking at surgery. And then there are a handful of trials on that are registered with the NCI looking at, there's one looking at abiraterone, there's one looking at CPLS-LT in the neoadjuvant setting. What will come of these, I think, would be interesting. But certainly in terms of looking at high-risk disease, we need to do better than surgery alone. And I think that looking at some of these newer treatments in the neoadjuvant setting would be the way to do it. The benefit also is we might get information pathologically about how they're responding. Whether that corresponds to any survival benefit is yet to be seen.
Oliver, have we left anything out in terms of new chemotherapy for prostate cancer?
Well, there are a variety of other tubulin agents that are underdeveloped, and then of course there are combinations.
Those would be what,
some of the
exabipalones?
Some of the epothalones. It's been a little bit problematic in terms of the neuropathies, and probably a little less active in prostate cancer. There's some sort of nibbling around the edges there. Most of the emphasis now that I see is going into novel forms of targeted therapy, which Matthew covered in his talk, novel forms of radiopharmaceuticals, which Matthew covered in his talk, and the novel forms of hormonal therapy, with the understanding really today that the androgen axis remains a key player late in the stages. So chemotherapy has taken a little bit of a back seat, but it's not completely on the back seat.
I'd like to actually open up the discussion as well about molecularly targeted therapies. XL184 is about the first, I guess if you don't admit that hormones are targeted therapies, but thinking of the new pathways, that XL184 is really a breakthrough for prostate cancer in the sense of being the first of those targeted drugs to have a measurable effect on the disease. And do you anticipate are there any other important studies ongoing that we haven't covered today in the targeted area?
I think I accept your comment that I think maybe there's been some disappointments with earlier targeted therapies, leaving AR aside, because that's really been a home run. I think the most important developments in the field have been recognition of the ongoing importance of AR and AR signaling in castration-resistant disease. But for example, the recent failure of other targeted therapies, ET1 targeted therapy, the failure of sunitinib at phase 3. These are disappointments, but if we look back, the evidence of, the early evidence, phase 1-2 evidence of activity was relatively modest. I think the observations with cabozantinib or XL184 are very provocative. It is early. So when you see a set of observations that you haven't seen before, it's far from certain what you can expect that to translate into clinical benefit. But I think, as we talked about earlier, the path to understand those issues is well underway. So it is an exciting time in that area. Mm-hmm. And it's maybe a case where I think it may be true in other malignancies as well. There is a role for pragmatism. So while we can try to explain the clinical observations looking back, they in fact couldn't have been well predicted looking forward, and this was why the broadly cast net approach was very desirable.
It doesn't diminish the importance of it,
Yeah.
that we don't understand it. But it also carries with it the potential of understanding a whole new field of chemotherapeutics or targeted therapies, and that is modifying the stroma, the bone environment, which I think could be extremely interesting. Eleni, do you see any other major opportunities in terms of targeted therapies?
Well, I would like to go back to what Oliver mentioned during his talk. We have followed the route of combining a lot of these reagents with docetaxel. This has proven to be either a mistake or just that these agents are not actually potent. And one of the recent failures, apart from ED1, was bevacizumab. In my mind, looking at the PFS as compared to the overall survival, we may have missed a subset that actually does benefit from such an antigenic reagent, and we've missed that opportunity. Coming back to that, there's a few trials, and off the top of my head right now, I would remember the lenalidomide in combination with docetaxel that is currently ongoing. Then there's the docetaxel plus minus dasatinib that we mentioned seems to be involved in probably the AR non-genomic signaling, or also there's a lot of data with regard to its action within the bone microenvironment. So that remains to be seen, and hopefully if we at least don't see it in the whole cohort that will be tested, we will be able to tease out the patients who do get a benefit. There's a couple more that I can think of one antigenic inhibitor that's going right now into phase 3. The disquinimod, that's also going to be something interesting to look at the chemo-naive. But now it's getting to be an area that's really filling up quickly with approved reagents. So it's getting more and more difficult. It's reminding you of the renal cancer case. I mean, we're going to end up probably not looking at overall survival at some point in time like then, looking at PFS a lot. So hopefully.
Jason, you and I have had discussions about the idea of also looking at targeted drugs that modify the radiation response and maybe improve radiation killing. And maybe you want to take a moment to describe what we had in mind there.
Yeah, no, absolutely. We've had discussions about developing a standardized platform for testing novel targeted agents and assessing their radiosensitivity. And so basically as radiation sensitizers. So currently we're using a variety of agents in standard practice as quote-unquote radiosensitizing therapy. We do that with chemotherapy quite regularly. A number of agents, cisplatin, gemcitabine, others, are known to be very potent radiation sensitizers. And the question becomes, how are these targeted therapies acting? And so in order to do that, we need standardized assays, and that's what we're sort of building a lab to be able to do.
I think it begins with having a collection of cell lines that can be useful, particularly prostate cancer cell lines that'll tell you whether there's a pathway that can be modified that will enhance radiation
absolutely.
sensitivity.
Genetically well-characterized cell lines is where this needs to start in vitro, absolutely.
Right. Have we made progress in that regard, Oliver?
Not as much as you would think. The progress that has been made, however, is interesting, and it's particularly around xenografts. So cell lines we typically think about in vitro propagation, whereas the xenografts are quite often propagated in vivo. A fellow by the name of Bob Vasella out at University of Washington has done some beautiful work there, and molecularly characterizing the xenografts in a way that will allow probing with therapeutics in relationship to the genetics of the tumor. And there's some really nice work evolving right there. In fact, some of the abiraterone data with splice variants has actually come out of that work at University of Washington. Yeah. So, as we move forward, cell lines are one model, but I think xenografts may represent another, and I'm a little more enthusiastic on the xenografts right now.
Yeah, right. Well, we're going to depend on you, Adam, to provide the tissue for doing that, which is really one of the rate-limiting steps. Yeah, okay. Matt, what about in supportive care? Are there any other major developments coming up besides denosumab? It was a major advance in the last year. Are there other bone-directed therapies? The other issue is, are there any ways of modifying the effects of hormonal therapy that are promising?
Sure, so I think there's a couple of issues on that front. I think there's now the issue of treatment-related osteoporosis and fractures has been well recognized, and there's been progress in that front with the observation in a large randomized trial that denosumab prevented vertebral fractures in men on ADT. The other part of sort of the issue of bone-targeted therapy that's attracted a lot of attention is whether or not the approach in general has the potential to delay or prevent the onset of metastases. Earlier trials of other agents having failed in that setting, and very soon we'll report on data with denosumab showing prevention of metastases. I think that'll have a number of important effects. The impact of that will be important. It may be a valuable therapeutic agent in that setting, but the other thing is I think there'll be great recognition of that clinical trial design as a model to evaluate other agents, including other agents that more traditionally target the tumor.
So if we expand the use of denosumab in earlier disease, are we going to have more problems with osteonecrosis of the jaw, for example, and are we going to have to pay more attention to that?
Yeah, I believe so. So all therapies come at a cost. We've talked a lot about that today, and this is certainly no exception. One of the main side effects of the osteoclast-targeted therapies, zoledronic acid and denosumab, when given in the dose and schedule for metastatic disease, is this condition called osteonecrosis of the jaw. And that certainly has been observed when the drugs are given frequently. So we do need to weigh that risk with any potential benefit.
Mm-hmm. One of the concepts that seems to be growing, at least in attention in the research area in targeted therapies, is intermittent use of therapy, because long-term use of therapy without a break is often not tolerated terribly well for a variety of reasons, liver, GI toxicity. In hormonal therapy, is that idea actually due for a little more attention?
I believe it is so, and we've had some recent data coming out of the GU ASCO we just attended, suggesting that at least it's equivalent, and there's some probably, if the way I interpret it, less long-term toxicity. If there was a different scheduling, some people prefer the 6-month versus a 9-month. I think we're all going to reach a consensus, but I think it's a very valid approach to save some of this long-term toxicity, especially in those androgen signaling dependent patients who go on for several years on this type of treatment.
Matt, how reversible is the hormonal the deprivation of hormones, the toxicity related to that? How reversible? How quickly do you see changes when you stop therapy?
Yeah, it's a good question. It's not been well studied. There's quite individual variation in recovery of gonadal steroid levels, so it depends on age and duration of prior treatment. But in the classic paradigm of treating patients, say for 9 to 12 months before a treatment holiday, they tend to recover pretty quickly. But by that I mean within 6 to 12 months, so it's still a fair amount of time. I think a recognition of potential side effects of ADT has given greater rise to caution in starting therapy. I think what we're going to be seeing is more intensive treatment for the patients who most require therapy and avoidance of therapy in patients who don't.
Yeah.
And one of the, I think, very provocative concepts will be to look at maximum androgen blockade in the intermittent setting. So, for example, would the combination of standard ADT plus abiraterone for a year result in a much longer remission or treatment holiday?
Right. Well, maybe we could turn to the audience and ask if there are any questions for the panel, any issues that you would like to hear more about that came up in the session this morning.
So the question is, we've talked about the role of osteoclast-targeted therapies and other bone-targeted therapies in advanced castration-resistant disease. What about the role in earlier disease? It's a really fair question. Thankfully, the truth is that androgen deprivation therapy does a very good job of cancer control, even in patients who present with metastatic disease. So I'm at equipoise about whether there's any value to the addition of bone-targeted therapy in patients who are hormone sensitive. And in fact, I do not recommend it routinely, except for patients who've already experienced complications. And those are the outliers who we know about who present with extensive metastatic disease. The challenge in clinical trial design of the question to pose would be a very long life cycle, looking at trials that would go on for 5 to 10 years of follow-up. So at this time, I couldn't recommend it, and part of the appeal of looking in, say, the castration-resistant non-metastatic space has been the patients are at sufficiently high risk to do trials during our lifetime.
I might add a little bit to that because it was kind of interesting. I had become pretty skeptical about the bone-targeted issues earlier in the course of the disease. And then there was the MRC study from the UK. Now, these were metastatic patients, but hormone sensitive, treated with an agent called Quadrant, which we don't even utilize here in the US. But the Quadrant studies showed that there was a survival benefit for patients with metastatic hormone-sensitive disease. And now there are other studies looking at zoledronic acid in that setting. But to me, that was a bit of a surprise. I just never thought that would be true. But, I mean, it's a prospective, randomized, significantly powered study, and the results are the results.
And I was sincere when I said I was at equipoise, because we, in fact, been involved in the national trial that you described. So this is a national study looking at the issue of whether immediate addition of zoledronic acid would improve outcomes compared to the current standard of initiating therapy upon development of castration-resistant disease. It's nearly fully accrued, and hopefully we'll have the results in a matter of the next few years. But that will go a long way to addressing the question you pose.
Actually, I think that's a terrific question. And really, if I were to repose it, I might word it slightly differently. But the question is, now that we have newer agents, do the patients who are resistant to these newer agents behave in the same way as the past patients that are resistant to hormonal manipulation? And the answer is, I don't know. And I think we're going to need to empirically derive some of that data going forward, because it very well could be, and I had one slide in my presentation on taxane downregulation of androgen translocation to the nucleus. And if in fact that is a potential mechanism for taxane action, and you introduce newer, more effective hormones before using it, it could be the taxanes may not be as effective when given second line post-abiraterone, et cetera. So I think we need to have more data to really answer your question, which I really like.
Well, this is, of course, the value of the randomized controlled trials, because if the theoretical disadvantage you pose is real, then in the 302 trial, we may not see as much of a benefit as we hope to see. I think the question you pose also raises a related issue, and that is, when is the correct time to stop abiraterone? And, for example, in men who fail primary androgen deprivation therapy, the standard of care is to continue their castrational therapy. So by inference, wouldn't it make sense to continue abiraterone beyond progression? And that was not part of the clinical trial design, but I think will remain an open question. But there's certainly good rationale to consider that approach. Obviously, it would come at the cost of dollars, potential side effects, and unknown drug interactions with subsequent salvage therapies.
But at that time that abiraterone becomes ineffective, would that be the time that in the future some of these androgen receptor inhibitors become potentially useful, theoretically?
So the foundation therapy issue that Matthew brought up is a very valid issue, and I think it might be addressed by smaller studies, but then it becomes, as you're bringing up, more and more complex. What is going to happen with the novel anti-androgens that are completely different from what we're used to, bicalutamide and the like? And with moving up all of these treatments earlier in the disease, one would probably anticipate something similar to what is happening with diabetes and arterial hypertension. It's a possibility, but then the dollar issue comes up. So.
One thing that I think all of this points out is that with the change in the drugs that are available and the combinations that are available, we really are going to need to try to study hormone resistance at a molecular level to try to understand, is it all the same, or do you get a different profile of disease and molecular disease as you use combinations and different agents? And I think that's really an important question, because if you find in some patients that the androgen receptor is markedly elevated and there's still evidence of androgen responsiveness despite abiraterone, then it makes sense to use medivation. But if the combination, you find a cell that's totally switched off and it's activated another pathway, then that changes your approach totally.
You're actually raising the great issue of biomarkers and prognosticators of outcomes. That's
this
what we
is
need.
a disease, right? This is a disease that doesn't have biomarkers right now, except for PSA. Right. And that's really the importance of what Ron DePino was pointing out, is that there are other molecular things that we ought to be thinking about as potential indicators of new paths of disease and new treatments opportunities.
That's a great question. And I think I was careful in my talk to say that whenever you see a pattern of activity that was not previously seen, it is hard to be certain about what that will mean for patient benefit. And ultimately, it'll require phase 3 trials, and there are plans for a survival trial to determine whether or not these effects that are being seen translate into an overall survival benefit. That'll be the ultimate proof. But in the meantime, how do we sort this out? It is very clear that this is not just a bone scan effect. There's other very supportive data, including decrease in measurable soft tissue disease outside of bone sites. So that's more of a direct demonstration of an anti-tumor effect. And then there's other information to indicate a potent effect on bone, including these very dramatic effects on bone turnover markers. Patients who are symptomatic often have marked improvements in pain. So there's a variety of supportive information beyond the bone scan. What other imaging is next best? We've thought long and hard about this. Our opinion is that total body MRI will be the best way to address this. Almost any other functional imaging, so bone scans are functional imaging tests. Any functional imaging tests, such as FDG PET, sodium fluoride PET, carry some of the same concerns about whether or not you're affecting metabolism or blood flow. And the other part, of course, is that many, if not most, patients do not have informative FDG PET scans with prostate cancer.
I'd like to raise one final issue. We heard it several times in the morning's presentation that the PSA may not be the most reliable indicator of what's happening to the tumor. I grew up in an age when we believed that it was, but this study and some of the studies of disease progression that were discussed cast doubt upon this. How do you feel about this now clinically? Do you feel relatively comfortable practicing depending on a PSA or not?
We need better biomarkers. There's no doubt about that. Not only for determining what's going to be a more aggressive disease, but perhaps sparing patients upfront treatment altogether. Perhaps helping us decide which upfront treatment, even for localized disease, that specific patient is likely to do better with. And also, I mean, this is another issue that we think about in radiation oncology is, are there germline determinants or potentially tumor determinants of how a patient is going to do with a certain technology that we're employing? And also, are they at more risk for side effects from that treatment, for example, in the germline to develop proctitis as an example. So
epithelial damage. Right.
There is a wealth of information that we need and we don't have yet.
Yeah, and PSA is just too simple at this point to be able to tell us everything. Oliver, any final thoughts? About PSA?
I was going to comment that PSA is a pretty nice marker for differentiated prostatic epithelium. And its fault is that it is a marker of the most differentiated component of the tumor, not the least differentiated component, which is the one that is the greatest danger to the patient. We've all seen these leads in 9, 10 patients with bulky tumors and very low PSAs. And we need something that will get closer to the heart of the issue. And PSA adds value to what we do, but in no way is it the final answer. We need much, much more.
That's very interesting. So maybe a rise in PSA is a good sign. Differentiation. Maybe that's what's happening with XL184. Well, I want to thank everybody from the panel and the audience and the other speakers for a very interesting day. And I think we all appreciate how fast this field is moving, and we'll have to do this more frequently. Thank you.